And I'm going to turn it over to Chris Salerno, who is going to introduce our panelists. Chris.
Good evening, everyone. Welcome to the second in our 2021 forum season. Tonight, our topic is faith in medicine in the year of the COVID-19 pandemic. The discussion will be amongst three physicians who are longtime members of St. Michael's: Charlie Emerson, Adair Heath, and Mike Wood. Each speaks from his personal faith and medical position. All are officially retired. Each has very different medical training and practice. The last 15 minutes of the hour are reserved for your questions and answered, as Sue has just explained, using the chat format of Zoom. The first speaker will be Mike Wood. Michael Wood is an orthopedic surgeon specializing in hand surgery. He received his MD from McGill University Medical School in Montreal, Canada, then trained as an orthopedic surgeon at the Mayo Clinic in Rochester, Minnesota. After a brief stint as staff surgeon at Ohio Medical School, he returned to Mayo in Rochester as staff orthopedic surgeon for 24 years, becoming CEO of Mayo for 4 years. He currently serves as the supplemental consultant at the Mayo Clinic in Jacksonville, Florida, and has helped a lot of our parishioners manage to be seen in Jacksonville, Florida. He is also professor at the Mayo Clinic School of Medicine in Rochester, Minnesota. The next speaker will be Charlie Emerson. Charles trained in internal medicine at the University of Virginia and the University of Pennsylvania. His career in academic medicine took him to the Universities of Chicago and Massachusetts as professor of medicine. He has served as the president of the American Thyroid Association and continues to actively write in the field, pressing for civil discourse among physicians and patients for understanding the emotions of patients. He stresses empathy as an important element in the art of medicine, which was published by him in 2009. His insights tonight are applied to the pandemic in which we live today. The third speaker is Adair Heath. He's a psychiatrist specializing in child and adolescent psychiatry. Adair trained at Stanford Medical School and practiced psychiatry in Portland, Maine for 27 years, where he held associate clinical professor positions at Tufts Medical School and then at the University of Vermont Medical School. Seeking new experiences, he then spent 12 years in Australia working in the National Health Service as a child psychiatrist. Returning to the US, he and Carol chose to settle in Fort Myers and promptly joined St. Michael's more than a decade ago. So we have three wonderful gentlemen. All three clearly have diverse training and experience. We welcome their comments on how their faith also has influenced their thinking and acting regarding life and medicine in the coronavirus pandemic. Each will have about 15 minutes, after which the whole topic will be open for discussion with all of you out there in the audience for about 15 minutes. In other words, we've got an hour program. Your questions should be submitted to Susie Wilson, who is managing the chat feature with the able help of Sue Van Oss in Susie's brief absence. Thank you and enjoy the forum. So Mike, the platform is yours.
Well, thank you, Chris, and good evening to everyone who's attending the forum. And I have to make a little apology up front that I'm getting signs that my internet is unstable. So we may get to a point where all of a sudden you see me holding my mouth open. If you do, you can check my oral hygiene and get back to me on that. But when we were talking about this forum, Dr. Emerson and Dr. Heath and myself thought that COVID is really on everyone's minds at this point, and we should spend some time in maybe talking about how COVID relates to our personal lives as well as our planning and things of this nature. So what I want to do in the next few minutes, perhaps 10 minutes or so, is talk a little bit about understanding COVID-19 as a disease. And what is it? How does it spread? What does it do to your body? How deadly is it? And how do you protect yourself? So with that, let me start with what is it? COVID-19 is an infectious disease caused by a type of coronavirus, which is one of many types of viruses. And viruses are different from other disease-causing pathogens like bacteria or fungi, in as much as they cannot replicate themselves. So what they need to do is to invade a host cell, take over its protein synthesizing mechanics and replicate themselves with that. So in essence, when you get a viral infection, you're turning your normal cells, your healthy cells, into virus-producing evildoers. So that is now coronavirus as a virus, one of many, but it's not new. It was first identified in the 1930s. And it wasn't until the 1960s that it was associated. At that time, the diseases were pretty low grade, kind of comparable to the common cold, with a chronic cough, maybe a low grade fever. And in fact, even today, coronavirus accounts for about 25% of what we would call a common cold. However, in 2003, that all changed because a coronavirus mutated into SARS. And SARS first evolved in China and primarily affected Southeast Asia. But SARS became an epidemic in that region of the world. And it accounted for approximately a 10% fatality rate. So it was one of the first times that a coronavirus was associated with a fatal disease causing situation. And I remember SARS pretty well because at that time, I was on the board of directors of the public health system in Singapore. And Singapore basically shut down for 2 to 3 months. And it took them almost a year and a half to recover from it. But they did come through it, as did all of Asia that were affected by SARS, simply by public health measures, masks, distancing, things of this nature. And never did a vaccine arise that they could use to control it, but it was controlled. And then again, coronavirus didn't really rear its face again until about 2012. And that was in Saudi Arabia, where there was the emergence of the Middle East Respiratory Syndrome, or MERS. And that lasted until 2015. And that was quite a virulent disease. It accounted for a fatality rate of almost 34%. But it too was eventually brought under control without a vaccine by public health measures. That brings us to December 2019, when COVID-19 emerged in Wuhan, China, and that is the situation we're dealing with today. Although COVID-19 is considerably less fatal than SARS or MERS, with a fatality rate in the range of 4 to 5% overall, it is much more highly contagious. And that's why it has gone from an epidemic in a region to a pandemic in the world. So let's talk about how it spreads. The main mechanism for spread of COVID-19 is aerosolized droplets from an infected carrier's mouth or nose. And that's why face masks are so effective in preventing spread, particularly when the face mask is used in the appropriate manner, and that is covering both the nose and the mouth. And you can see as you walk about Fort Myers and Sanibel that a lot of people eliminate the nose from it. And that just isn't effective use of a mask. The other areas that make it beneficial is avoiding crowded places, avoiding indoor settings. So the more you're outdoors and in sparsely populated areas is very helpful. The virus can survive on surfaces, but not for very long. So, I mean, at the initial outbreak of this pandemic, there was a lot of concern about what do I do about my groceries and my laundry and who was last in my car. But to date, there has been almost no evidence of significant disease transmission from surface to nose contact. It is transmissible from fecal to oral routes. It also can cross the placenta. But again, these are negligible routes of transmission. So by and large, it is really aerosol droplets when you're talking to someone who's having oral or nasal secretions that go into the air. It is not thought that the virus is very robust. In fact, it is very effectively killed by simple soap and water, and also by household disinfectants. So what does it do to the body? Well, in about 80% of cases, it does very little. It either is asymptomatic or causes only mild symptoms of a low-grade fever and a cough. But in about 20%, infections can be more severe with high fever, severe cough, shortness of breath, sore throat, extreme weakness, muscle pain, diarrhea, or skin rashes and sores. It is in this group, after an inoculation period of 1 to 14 days, that extremely serious symptoms of pneumonia, heart disease, stroke, kidney and liver failure, limb gangrene occur. Lingering neurologic symptoms, including inability to concentrate, confusion, depression, or Guillain-Barré paralysis, are common in the severely affected group. One study reported that 2/3 of patients, after 30 or 60 days of a severe infection, were still complaining of significant symptoms, including fatigue, cognitive problems, diminished lung capacity, and shortness of breath. And a recent study from Oxford University reported that 1 of 8 COVID survivors at 6 months had lingering neurologic or psychiatric symptoms, including dementia, with people that did not have these symptoms before the infection. So the question is, how deadly is it? Well, serious illness and fatality can be the magnitude of the initial viral load, males being more affected, and blood type A is more affected. But the most significant factor is age and pre-existing medical conditions, especially lung, heart disease, diabetes, high blood pressure, immunodeficiency syndromes, and severe obesity. If you mean less than 1/10 of 1% are fatal, that's 1 in 1,000. From age 30 up to age 39, less than 1% or 1 in 100 will have a fatality. But from age 50 to 64, this goes up to 14.4%. Age 65 to 74, it goes up to 20.8%. 75 to 84, 27.4%. And for people over age 85, fully 32.8% will have a fatality rate. That's 1 in 3. So how are we going to protect ourselves? Some things we all know: avoid indoor gatherings, social distancing, and the use of masks properly worn over both the nose and the mouth. Masks help the wearer, but they especially help preventing the dissemination of disease to others. That brings us to vaccinations. Vaccinations are now considered we have two FDA, emergency use FDA approved vaccines available, and that's the Pfizer as well as the Moderna. Both are engineered RNA substances, so they're artificial substances. They're both about 95% effective. They both require a booster, Pfizer at 21 days and Moderna at 28 days. Both are difficult to distribute. They require a continuous cold chain process. For Pfizer, that means it must be kept under minus 70 degrees centigrade, and it has an extremely short shelf life. So once these vaccines are thawed, and if they're not used within 6 hours, school's out. The Moderna vaccine has a little bit more of a latitude. That has to be kept at about minus 8 degrees centigrade, but it too has a very short half-life. With the single dose, both start to offer protection at about 12 protection, but they both require a booster, and full immunization occurs approximately 14 days after the second booster. There are other vaccines that are coming on the market and imminently. Johnson & Johnson has just submitted February. It's a very traditional vaccine. It uses a harmless virus vector. It's probably somewhat less effective for preventing disease in the first place. For the most of what we're seeing in this country, it's about 66% effective, but it is 85% effective for avoiding moderate disease, and it's basically 100% effective for severe disease and hospitalization. And that's what we're trying to get with the vaccines, is avoiding those severe cases with fatality and hospitalization. It has a long shelf life and it's relatively cheap. Then there are other vaccines that are coming online. Novavax is one that they're talking about. It's in trials yet, but the early data would indicate that it's quite favorable. AstraZeneca is another vaccine that's being used in the UK, and recently it's come under pressure because it has been shown not to be quite as effective for the South American variant of COVID in terms of preventing disease, but it still is effective in preventing the severe disease, fatal disease, and hospitalization. So it still should not be taken off the charts. And finally, Russia has something called the Sputnik 5, which is supposed to be very effective. We don't know very much about it because it hasn't been reviewed, but it is being distributed. And there's probably about another 100 vaccines that are in development. Whether they'll ever make it to commercialization to market is uncertain, but our hope is kind of that what we have online is going to be effective. The take-home message that I would suggest is, when you have an opportunity to get vaccinated, do it. It's life-saving. It saves the medical resources, and the complications of vaccination are extremely minimal. They are all safe. So let me finish up with a prayer, and that is that herd immunity will render COVID-19 as innocuous as the common cold, and that globally, the world will be better prepared for the next pandemic. So with that, let me turn it over to Charlie Emerson.
Thank you, Mike. That was a very good review of COVID. I'm not going to say very much about it in my remarks, but maybe I'll give you a little bit of insight as to how this information is generated. Uh, I'm going to try and highlight at the end of my talk at least 3 principles of Christian faith that might be considered a guide to the ethical and rational practice of medicine. I'm going to give it from the point of view of a physician, and I want to recognize at the onset that in the care of people who are sick, many people are involved, many people are important for delivery of that care. But obviously, we can only cover so much in this period. Just to give you a word about my background, I have really nobody in my family except my aunt was in the medical field. But my parents were missionaries in India. I went to boarding school in India, and my mother was extremely enthusiastic about medicine, and she, without any training, undertook vaccination programs, tuberculosis presentation, and was really one that encouraged me to go into the medical field. Also, the advantage of going to a small school was they could do things that were a little bit different. In 7th grade, I took a course called Anatomy and Physiology. It was life-changing for me. I had an A in that course. Prior to that, I always made B's and C's, and it really gave me some confidence. I found it fascinating. I also took part in some medical things out there. We had a eye camp where over 100 people had eye surgery in 2 or 3 days. People were lined up. They were given a diagnosis. A tag was handed on them, and the next day they were just marched right through the one room where this surgery was done. Moving on to my medical field and skipping all my training, I suppose, at least the first part of it, as Chris has so nicely introduced us, my medical specialty was internal medicine and endocrinology and metabolism. But my practice setting was as a medical educator. We called it academic medicine. And I was sort of full-time, I was salaried, and I was based at the medical school center. But in my career, I at one point was going to 5 outlying hospitals as an endocrinologist, which was really a manifestation of all of the turmoil in healthcare delivery, where organizations were jockeying for position to basically attract patients. So I'm going to start with a question about medical education. And in fact, I'm going to have a series of questions here. So the question is, how many years of medical education should a doctor have in order to practice medicine to the best of her or his ability? Well, at first glance, you might say medical school is 5 years. But the answer to this question is a lifetime. You must always be a student, because as this COVID epidemic has shown us, we are always learning. So I was involved as an academic medical person in teaching and exchanging information with people at every level of their training: medical school, internship, residency, fellowship, which is kind of the subspecialty, and then postgraduate courses. Where does the information from how to treat diseases come from? Is it coming from textbooks? Where are textbooks getting their information from? In fact, textbooks are used very little in medical education. Most of how we learn is based on what is published in journals. And in order to publish in journals, one has to use the so-called scientific methods. Now, I'm speaking to a lay audience here, and I'm trying to sort of get an understanding of how this information is generated. So one of the things to point out is that in the scientific method, what we do is we measure things. We measure the level of blood sugar, etc. And you can understand that it is very difficult for us to measure pain even. We have a scale for pain, but we don't have a machine that will measure it. We can't measure emotional stress. We can't measure how a disease impacts people in their global life. Is information kept secret by doctors? I mention that because there's a series of textbooks that are called endocrine secrets, cardiology secrets, and they sell very well amongst medical students. And I often wonder if patients think that there is a conspiracy to keep information from them. I think the answer, hopefully the answer, is that actually everybody now has access to the same information that doctors use in their practice. That's the peer-reviewed medical journal. And you can get that information through the National Library of Medicine and many websites. But this may be something that Dr. Heath would want to comment more about. We do have a tendency to be concerned about conspiracies to limit our rights in many ways. And I'm not saying that this is not a valid thing, because this does happen. The other thing is there a conspiracy to prevent people from publishing? One of the things I do, I'm an editor of journals. I'm still associate editor of one journal. And I can tell you that authors and people that want to publish in this field, they may not be able to publish it where they want it, but they usually are able to publish it. So nobody restricts what can be published except the journal itself. So the challenges of knowing how to treat diseases in all patients and people are infinite. Even the rarest diseases have maybe 100 variants. You know that every snowflake is different. And that's true with every person. Every person reacts a little bit differently to a disease. But we have to understand that practicing medicine is more than simply practicing the scientific principles. An understanding of ethical principles and the theories of rational thinking are very important when we try and decide what is best to do, what is right to do. And the point being here that the scientific method, our research that we publish in journals, by and large, cannot give ethical answers. However, their ethics is entering the medical literature. It's been there for a while. And what the stress of ethics is in this, and I just finished reviewing a big guideline statement as the editor for one of the most severe forms of thyroid cancer. And the ethics is very much involved in that. But what the emphasis is on there is beneficial. What's beneficial, what's harm. So you try and balance benefit against harm for the patient, but you don't get into some of the other things. And that's where faith comes in. Now, what I'd like to say is that there are a number of things that faith needs. We need faith because when we practice medicine and when we deal with patients, and this goes for everybody, we have to be able to discern good from evil. We have to have empathy. We have to have compassion. We have to have reverence for life. And this is not just people, it's all life. And this gets into a problem because for the physician and the researcher, because some illnesses, you cannot do the kind of studies that are important in order to determine rational treatment. The discovery of insulin, the availability of insulin, which was life-saving, involved studies in animals. And this is where it becomes very difficult ethically. All of these concepts are guided by our faith. That's where our religion comes in. So I'd like to close by just highlighting 3 areas. One is that respect for all persons is important, all life and all creation. And I use that example. You cannot practice medicine properly if you relate only to Christian physicians. You have to work with everybody. You have to have the same respect for everybody. And I give a biblical example for that of the sermon, the Good Samaritan, where Christ highlighted the Good Samaritan as somebody who was an outsider who had better developed, more developed ethical and Christian principles than perhaps some others. The other is that you have faith in using the gifts that you have. You might say, well, you know, what's the point in life? But one of the things my mother taught me, I suppose, is that you do the best you can with the gift you have. And a biblical example for that would be the master who gives his servants money and says, I'm leaving this with you, take care of it. When I come back, I will be back. And when he comes back, he rewards the servant who did something with this. And I think he also condemned the person who did not do, that is the master in the parable. And the third is that as you work in whatever area you work of, as a physician, it's easy to become cynical about things. You have to be in awe. Your faith allows you to be in awe, not despair of yourself and all around you. The example for that is Christ's admonition to people not to worry about everything about them. Consider the lilies, how they grow. They neither toil nor spin. Yet I tell you, even Solomon in all his glory was not arrayed like one of these. But if God so clothes the grass, which is alive in the field today, and tomorrow is thrown in the oven, how much more will he clothe you? Thank you. Adair, it's yours.
Adair, unmute yourself.
Good. I'm going to rush this along because we don't have as much time as we thought. I'm just going to say a little bit about my faith journey, which is probably very different than many other people's. but it did prepare me for psychiatry. I attended church until I was 14, and then at 14, I told my father I was no longer going because I no longer believed in God. The reason I was feeling that way was that our family was struggling with my mother, who had major depression and serious substance abuse of alcohol and narcotics. There were frequent suicide attempts. There was embarrassment for all of the family. There was sometimes violence to my father. This led to real suffering for her, for my father, for me and my brother. My mother eventually killed herself when I was 26. Ironically, I was in the last month of my medical surgical internship and was about to start my residency in psychiatry. I couldn't understand how a merciful and loving God could allow all of this to happen. So I gave up on God, turned my back, and looking back, I know God did not give up on me. I came to Christ at the age of 49 in a somewhat aha moment. I was practicing medicine and in charge of a department in a teaching hospital in Portland, Maine. But I was struggling. I was physically exhausted and mentally exhausted. I don't think I would have survived except for the love of my wife, Carol, support of my father and friends, and years of treatment, psychotherapy, and 5 years of analysis. So I had come to the end of my own strength and I needed God. And that's, I turned to God, who helped me to forgive my mother and to forgive God. And this relieved a great burden of anger and guilt and shame. I discovered God had never abandoned me, but was patiently waiting for me to realize I needed him and to come to him for health. Over time, I've found ways to use my faith and biblical knowledge to put God into my psychiatric work. However, as Charlie has talked about, there are certain ethical principles and laws that constrain how a doctor can use their faith with their patients. In essence, it's some things belong in the realm of God, and some things have to be rendered to Caesar. So you must obey the laws and the ethics, and they have good reasons for being. In the doctor-patient relationship, there's a power differential because the patient's coming for health, and supposedly the doctor has that health. And you have a fiduciary duty to always act in the patient's best interest and not impose or proselytize your beliefs onto the patient. So I kept my beliefs to myself. I did not pray with patients, but I prayed for them. Before the day began, before sessions, I prayed for guidance and wisdom. Sometimes during sessions, even silently, I would pray for some guidance from the Holy Spirit. I prayed for God's discernment so I could separate what I thought was coming from the Holy Spirit from my own thoughts and my own agenda. Now, most of my work was in the public sector, and I worked with other professionals. So it was mainly in my small private practice that I saw people individually or as families. I was mostly involved in teaching, supervising staff, supervising residents, doing consultations for pediatricians, and teaching medical students. So that's where I came from, and my faith was very important. Even after years of help, psychotherapy, I needed God. That's what I needed to really be fully healed. Now, the second part of my talk is about the mental health effects of this pandemic. We've almost come to an entire year of this pandemic being in the United States. And there has been a great deal of suffering, fear, depression, and loss that people have experienced. Some of this is from the mitigation measures that we've had on and off, and a lot of it has been the effects of the pandemic on us. There's fear of getting it, and as Mike has described, particularly for older people, it's not only getting it, but it's dying from it or ending up with severe complications. There've been a disorienting loss of our roles, routines, and expectations. I'd say school closure has been one of the major factors, particularly for adolescents, but for children who need schools for a hot meal. But peer contact for adolescents is greatly missed. Economic effects. At one point, we had 10 million people unemployed, some now permanently. 100,000 businesses closed permanently, some large, some small. How have people coped? Well, alcohol sales increased 54% during the lockdown and maybe have decreased since then. Ambulance calls and treatment in emergency departments for overdoses greatly increased. And people who have serious mental illness who were stable are now destabilized and have had relapses, as well as stable substance abusers who now have returned to substances. We mostly have early reports, surveys, newspaper headlines, but we do know the stressors I'm talking about are factors that have been found in definitive and longitudinal studies, and that those factors have been shown to lead to increased rates of psychiatric disorders. However, in the last few weeks, there have been 2 published articles in the Journal of the American Medical Association Psychiatry. And this has much more definitive information. The CDC gets reports from all the emergency departments in the US, and they've compiled 190 million emergency department visits since mid-March through December of 2020. Now, we know that most people, even people who are having a heart attack or some other serious problem, have avoided going to emergency departments. However, indicative of the severity of the mental health problems, mental health visits for all conditions is significantly increased, and there's been a decrease for medical surgical conditions warranting a visit. There's been a significant increase in opioid overdoses, intimate partner violence, and child abuse and neglect. These, compared to the same periods in 2019, are significantly higher now. A Japanese study showed that there's been increased suicide completion rates, significantly higher again in the 2020 period compared to 2019. And tragically, this is particularly high for Japanese men and women under the age of 30. There are high-risk groups who I think when we finally get the information and compile it, we'll find there has been significant mental health effects from the pandemic. I think people who have lost someone while that person was in the hospital with COVID and they were unable to visit them, or who only through a computer connection were able to say goodbye, and then they didn't have the rituals of funerals and family get-togethers, there's likely to be what's called prolonged or complicated grief. And this can go on to lead to chronic depression. I think frontline workers, healthcare workers, ambulance, police, have been under a great deal of stress. And there's been post-traumatic stress problems and guilt, particularly in the situations where triage has had to be used, as in Los Angeles, where ambulances were told not to take people they thought would not survive to the hospital and to leave them in their home. Essential workers are also at high risk. This includes minorities and women. Children and women have been affected by the increase in domestic violence and child abuse. And as I've mentioned before, the children being out of school has had significant problems. People who've been hospitalized for COVID but have survived, I think also are at high risk, especially those who've been in ICUs, and especially those who've been on ventilators for weeks at a time while they are sedated and chemically paralyzed. During a lot of that period, they finally have to be weaned in order that they can start breathing for themselves. And they are often in a delirious state that's very frightening. Well, there's some good news. Another Journal of American Association article reports that from survey data on breaking it down about stress symptoms in different age groups, that people over 65 years of age are actually coping much better with their symptoms than those younger. And it seems that maybe those of us who are older maybe have some wisdom and faith that comes from the experiences of having problems and mastered them, giving them tolerance and empathy for others, compassion, and in short, something called spirituality. Let me just finally close to say about vaccination. Vaccination, it's marvelous that within less than a year, we've been able to develop and approve, test and approve 2 vaccines and more on the way. However, the vaccine only works if it gets into your arm. And there are people who believe that vaccines are unsafe, and they have taken over often the internet. And this has led to a lot of misinformation and disinformation. In fact, at Dodger Field, where they were doing vaccinations, an anti-vaccine group disrupted the entrance, and there was an hour-long disruption of vaccinations in that situation. So this is going to be a difficult problem that we'll have to fight with faith and good information. As Charlie has pointed out, you have to go to the right sources to get this information. So I'm ending so we can go to questions and answers.
Thank you to all 3 of our presenters. What a marvelous presentation by all 3. I'm going to now start to move people over to becoming panelists. So you'll be able to now be seen and heard. And as I do that, if you want to be thinking of questions or reflections that you have for the panelists, and Charlie will moderate those. So please raise your hand if you have a question, and then Charlie can call on you as I start to bring people in, and we're happy that Susie is now able to join us as well. So if you have,
I may just give people some information. I'm working on a very small screen, and I also have Flutter, which means sort of compounding that. So I think any of the 3 of us who talked can jump in here. Because I may have difficulty actually. My screen is absolutely jammed.
okay. And we have lots of people coming in. We have about 36 screens. So let's make sure I've got everyone.
I'm here and I can help too, Sue.
Thank you. Okay.
Hi, Susie.
So if you have a question, if you want to raise your hand, and we'll try and.
I know Lee Cooper has his hand raised.
Okay, Lee Cooper, go ahead.
All right, well, thank you all very much. Many of us are about to receive the second Pfizer vaccine shot. 2 questions. 1, should we expect an adverse reaction to the shot? And secondly, related to that, are there steps that we should be taking before the second shot to avoid complications?
Mike, you want to try?
Sure. Lee, you can expect some reaction after the second injection. The second is not like the first. And so there's been many people that have had concerns, have had significant symptoms for about 24 hours after the second injection. It seems to be more prevalent with the Moderna vaccine than with the Pfizer, but both have that. And I don't think there's anything prophylactic you can do to minimize that. So I think what you should do is, prepare not to have any big plans for about 36 hours after your second injection.
Okay, thank you.
Mhm.
Any other questions?
Looks like there's one coming through on the chat. There's a question coming through on the chat.
And Anne Marie had her hand up.
Okay. To all the panel, how closely do you have to work with bioethics, medical ethics? There's mostly ethical exchange of ideas, or theoretical exchange of ideas, some practical or applicable ideas and solutions explored.
My question was about biomedical ethicists. How closely do you work with them?
Well, I can just say I don't work with them at all, but many journals will have a section where these issues are discussed. And the Journal of the American Medical Association now has many articles in that area. I know the psychiatric journals do. I can't speak for others.
Yeah, the other thing is that research protocols, generally, at least in the United States, many parts of the world require what they call an IRB, or Institutional Review Board, that basically evaluates the protocol, and they usually will have a bioethicist. Certainly, as I mentioned in this article that I mentioned, that I was sort of shepherding through the review process, bioethics was a big part of it because this was such a lethal disease. And so there were obviously emotional and physical stresses. One of the things I was mentioned that I wrote an article about empathy, an editorial about empathy. And one of the things we're trying to recognize is that the point of view of the patient as to how they view their illness does not correlate very well with the grading in terms that we use, like the death rate or various complication rates. People with very serious illness, at least, and Adair may have a comment on this, may not appear particularly distressed, although they may be. On the other hand, what the trigger for me writing that editorial was an article in the journal on this disconnect between how the patient perceived the seriousness of their disease and how it would be graded in terms of the guidelines as to how serious it is. And also somebody was very distressed and wrote a poem about her thyroidectomy, which I thought was a very well-written poem. It was a loss of her thyroid. She viewed it as a loss, even though we were able to replace that medically. So that was where it was sort of a plea for us to try and understand what the patient's going through.
Anne-Marie?
Thank you.
Yeah, my question is, we heard a lot about the support mental health issues with patients and the general public. What measures are being taken to protect the mental health of the care providers who are in the front lines of all of this and are watching people dying constantly? It must be terribly stressful for them.
What about the Mayo Clinic? Do they do anything? What are they doing for their staff, for their nurses, for the people that are working with patients, at all levels? We've heard a lot about that, but not so much what's actually being done by institutions.
I don't know about specific hospitals. I do know people are certainly aware of it. I know that there are people volunteering who are retired to help people who are experiencing stress and mental health issues. I would assume many hospitals are making some provision for this, but I don't know.
That's the problem. We're all retired, so yeah, we're not in. We're out of the pipeline for some of the information. At least I am.
Priors and Adele.
Piper? Richard?
Muted.
Hold on, Richard, you're muted.
To
There you
all,
go.
to all the panelists, what does your faith look like under pressure? How does it work for you? What is it? What role does it play?
He's the guy who gave me that book to read.
The marriage book?
No, the book that he wrote for his family.
Well, I'll just say, I don't know, but I do feel that my faith has helped me in lots of, stressful and unexpected emergency kind of situations. But I have no way of proving that.
I would say that faith, I think one thing that faith does give you is trust. The understanding that you are going through this period, but that faith, you have some trust that things will get better. And I think that is a coping skill that is something that is very important, because it's so easy, if you don't have that trust, to not take things that would help what you're dealing with now. But certainly we can all imagine situations where we say, how would we react if if we were presented with this? And I don't know, maybe some people from that are on now might want to comment. I don't know how much time we have left. There's probably, all of us have information and have thoughts about this.
Well, if I could say that I think every time I was going into a surgical procedure that was going to be highly complex, I typically would say a prayer to myself, that I had some additional help. And I think that there are multiple times during the day when you're under pressure that it's very helpful, not only comforting, but supportive, to ask for special help spiritually.
And I agree with you, Mike, to ask for help. I think also part of you can ask for help from other people. Sometimes people feel they have to do it all on their own. They don't. And medicine is more and more working as teams. So there are people there to help you. But as you describe, I also would pray before or in the midst of a situation. And it gave me confidence. And I think the Holy Spirit was helping me and guiding me.
I agree.
I have a comment. It's not directly, but Adair said, and this is really true, the word team is showing up a lot in the medical literature. Our team did this, our team did that. I actually think in some situations it is not good in the sense that, for example, I keep coming back to this article, and one of the authors wrote that the team needs to let the patient know or whatever, discuss. And, you know, to me, that was very nebulous because you still have the concept of individual responsibility. So, you know, to give you an insight, patients often wonder why the doctor comes in and takes the same history that the person before took and the medical student. And it does seem aggravating, but it is oftentimes important. And so, you know, it's never going to go away, but you may hear the information about the patient being presented, but you need to know for yourself to get this straight in your mind if you're going to be, if you're going to help the patient.
Anne Marie, you had your hand up? Nope, you're muted. Hold on.
Sorry, I just discovered a way to do it without the hand raise function, and I was testing it. I'm sorry.
Oh, okay.
There's a shortcut on the keyboard. So,
Are there other questions out there?
I have a question.
Okay, Alan?
And maybe this is in relation to what Charlie just said, but I'm really curious that the vaccine is a result of almost a miracle, according to authorities. Do you suppose we could do the same thing with cancer? Could we address cancer the way we address getting a vaccine?
Well, maybe I could jump in on that. I mean, the two vaccines that are currently approved, they are unique in terms of they are messenger RNA vaccines. But that technology really came out of investigations about anti-cancer drugs. And the whole COVID-19 pandemic really jump-started, accelerated, you know, the science that's involved with that. So I think we can expect, even though the mRNA technology has been essentially a life ring for COVID, it has a lot of applications in terms of cancer and in terms of immunotherapy for cancer. So I think in many regards, as bad as the pandemic has been, it's had some benefits, and that is in terms of bringing that technology forward.
Good, Jonathan. Thank you.
Are there any other questions? Well, I want to thank all the presenters tonight. It was a wonderful, congratulate everybody for participating. And we hope we will see you not next week, but the week after. Next week is Ash Wednesday. And I think Bill will be doing a little something for Ash Wednesday, maybe before we sign off. Bill, you could just talk about that for a brief second.
Brief.
Yeah, just a little bit on Lent, customs and traditions, a little bit on the background of Lent, and your stories on how you have kept the season of Lent in your own lives and in your own families. So come along next Wednesday at 6.
Oh, okay, 6 church.
Thank you, thank you, thank you.
Good night, everyone.
Thank you, everybody.
Thank you very much to tonight's speakers.
God bless. Stay well, folks.
Have a great evening, everybody. Thank you.
Glad you got the vaccine, Susie.
Oh, it was a miracle today, Adair. Total miracle. Thank you.